Hello, I am Jeffrey H. Barsick. I am an Associate Professor of Medicine at Northwestern University Feinberg School of Medicine. In this module, I will be reviewing proper techniques for ultrasound-guided internal jugular venous access. So now we're ready to set up the central line kit and get our patient ready to do an internal jugular vein insertion. It's very important to consider the type of line kit that you're actually using at your institution. There is going to be certainly different variation between the kits that are purchased by different institutions. Here in front of me, I have a standard Arrow triple lumen kit. You might find that at your institution, another manufacturer making a kit may be Cook. I'm going to demonstrate the techniques on an Arrow kit and then discuss briefly where the variations would be between the different kits. First, you'll notice that there's an actual small drape in this kit. I recommend not using the drapes that are in the kits unless they're actually full body drapes, will cover the patient over their head and all the way to their toes. This is a very small drape and it has no use for us, so we'll put it aside. I have my lidocaine labeling we can put aside and then some gauze that I'll be using during the insertion. Now as we notice, you'll see that my triple lumen comes with caps already on it. Unfortunately, these are not lure lock caps, and I need to use them more for safety. These are needle caps, so I need to dispose of these caps and actually find out the caps that are used at my own institution. The caps that are used at your institution, again, will vary. We use here the CareFusion caps that I'm actually going to put on our line. As far as needleless connectors go, you can use positive displacement caps or neutral displacement caps. We went into more detail on the types of caps during the lecture, so I'm not going to go into it now, but it's important that at the least you flush through your caps. Now you'll notice that I put all the caps on just for the flushing step. I will be taking off the cap where my guide wire will be coming back. And of course that is the distal port, and as you can see here, on all lines, the distal port is actually labeled distal, and on the Arrow kit, it happens to be brown. However, on the Cook kit, it happens to be red. But you can always just look at the writing on the lumen, and it will say distal, and that's the port your guide wire is going to come through. The other thing you're going to notice is when I opened my kit, there was a lack of flushing material. Now, one advantage over the Arrow kits is some of the Cook kits actually come prepackaged with saline flushes that are already pre-drawn up. You need to take particular caution when you're drawing up flush for your kits to ensure that not only the outside of your syringe is sterile, but the contents on the inside are as well. And it is not acceptable to take an empty sterile bucket and fill it with saline for injection because, as you can imagine, the saline in that is open to the air, and the air is capable of having dust particles in it that can settle into the solution, and then when you're drawing it up, you could inject that into the patient. So per guidelines, the saline must be drawn up in a closed, sterile syringe that you can put on your field for flush. So the next step I want to do is I want to flush my line. So I'm going to take my flush, and I'm going to attach to the ports. I like to do it in a particular order that I have memorized just to be ensured that I do them all. I usually do brown, white, and blue, or if it's a Cook kit, I do red, white, and blue like the American flag. And I'll start with brown. I'll screw on my flush, squirt it through. Comes out the end. Then the white. And then the blue. Okay, so I'll put my saline aside, and I'll have my brown port ready to have the guide wire come through it, and I'll take off that cap, which has already been flushed. Now my line is ready. Let's just look at some other items that are in the kit. You'll notice on the Arrow kit that often preloaded on the syringe comes the catheter over the needle technique. This is otherwise known as the modified Seldinger technique. And what you have to be cautious of is if you mix up the catheter as a cap, then what can happen is you can end up cannulating the vessel with this needle, and the guide wire actually will not feed through this needle. So just remember that this is the catheter over the needle, and as can be seen, you slide the catheter over the needle into the patient and hub it, the guide wire would actually go into the catheter, not into the needle. So what you have to do if you want to use the Seldinger technique with the needle is you have to actually take the needle, which is here. So we'll put this one aside and we'll actually do the Seldinger technique with the needle, not the catheter over the needle. Load it on my syringe. Now there are some options for how I put my guide wire into the needle. Some kits actually have syringes that have openings on the plunger that allows you to actually feed the guide wire straight through the center of the syringe and through the needle. Other kits don't have this, and you'll actually stabilize your needle and feed your guide wire straight through the needle. I'm actually going to do the technique where I feed the guide wire straight through the needle because that's how most kits are. The only other variations you might notice from this kit to others is the actual suturing method type. This kit comes with a straight cutting needle that you use directly with your hands to suture your line in place. However, other kits may come with a curved needle and a needle driver that you can actually use the needle driver to use the sutures. The kits also often come with a stapling device. I don't really recommend using a stapling device because I don't believe that it secures your line in as is necessary. The colors of the securement device, a male and a female piece, will actually differ among kits. In the Cook kit, it's white and red as opposed to white and blue. Also, please note that I've gotten a Tegaderm with a chlorhexidine sponge dressing built into it. Now, again, defer to what you use for dressings at your own institution, but this is one of the recommended devices that is used for a dressing. Next, we're going to draw up our lidocaine in preparation for numbing the skin. Now, please take into account the level of sedation your patient has when you determine how aggressive you need to be with the lidocaine. I at least put a superficial wheel even in on patients that are heavily sedated, just because I'm still not quite sure what they're feeling. On patients that are more alert though, I like to numb the deeper structures. So our kits come with our lidocaine, so we'll take our lidocaine and we'll actually use a gauze to break it open. Now some of the kits will actually come with a filter straw. That will be a flexible tube that will fit on the end of a syringe, or it will be a rigid needle-appearing tube that has a blunt end. And these filter straws actually have a little white filter at the end of them, just in case there may be some microscopic shards of glass from breaking the glass lidocaine. Technically, these will filter that out. This kit does not have a filter needle, so we will just draw up with a regular needle. It is strongly recommended if your kit has a sticker that has lidocaine written on it, that you put it directly on your lidocaine syringe so that it's labeled. So now I'm going to draw up my lidocaine. And I'm using a smaller syringe just to draw it up. It doesn't really matter what size needle you use, I just didn't change needle. I'm going to get out the air. Just draw up the fill of the needle. One wants to take care never to recap your needle on the field. Some kits will actually have devices where you can actually put your needle in and reuse it. However, this kit does not have a device where we can place our needle and reuse it. It does have a sponge here that many people will use their needle and actually put it in and then reuse it. This is not recommended by the manufacturer because the way this sponge is made, it's a little more porous, and there's concerns that particulate matter from the sponge can actually break and go in your needle. So again, please be aware of the local kits that you're using and whether or not you can reuse needles after you put them in a sponge material. So not being able to recap the needle safely, given the fact that there's no other people performing a line insertion, I think it's safe to actually put my needle down on my field and not have anyone come near it. Now, as our next step, we're going to get ready and drape our ultrasound device. There are different ultrasound draping materials. We're using one from SiteRite. Again, you're going to need to know the different types you use at your institution, and your local trainer can actually teach you how to use it properly. So now we're going to drape our ultrasound. You have to kind of unravel it, and the actual probe cover is actually telescoped on itself. It's not rolled, like donut rolled. It's actually telescoped. So this is the telescoped or intussuscepted part, and your actual opening is right here. So what I'll do is I'll actually go through the opening and put some jelly on the inside, and that will help conduct everything we need to get a good image. So just go to the bottom of it, squirt out some jelly, come out, and then my assistant will help me, and we'll grab the ultrasound and kind of drop it into the bottom and then help me drape. Okay, 1 second. Okay, keep feeding it. Okay, perfect, stop. Okay, so I'm going to grab it on the bottom. Now you can take the end there and just pull it all the way down. Okay, and as he's doing that, I want to make sure that my surface here is nice and taut so that I get the best image quality. So I'll take my rubber band, I'll put it around, kind of double it up. And as long as it's staying nice and taut, I'm ready to go. Now that we've draped the ultrasound, we're ready to actually capture our image. And I see a good vein and pulsating artery on my screen. So if you choose, you can take a sterile marking pen and kind of mark where your ultrasound is and where you think your point of entry is going to be, just in case you want to take the ultrasound off. I have all my supplies ready. So I'm actually just going to go ahead and do first the triangle technique for the full insertion, and we'll actually discuss the other techniques as we go. So where I'm lined up now, it appears that I am approximately 2 centimeters to the center of the vessel. So about that distance back from the center of the probe, I'm going to make a wheel in the skin, injecting, making my wheel. Okay, injected, make my nice wheel. And then, depending on how deep the vessel is, I can either numb deeper with this needle if it reaches long enough, or I can change to the longer needle that's actually in the kit and numb deeper. So I'm going to aspirate, inject, aspirate, inject, aspirate, inject, aspirate, inject. Do it a few different directions so I make sure my patient is nice and numb. And once my patient's nice and numb, we're ready to start. If I think that they're adequately numbed, I can put my sharp in the sharp container. And now I have my finder needle. And again, we're going to do the triangle technique first, and then I'll show you the other techniques. So now that I have numbed the patient, I'm ready to actually use my finder needle to cannulate the vessel. You want your guide wire to be ready to go, so I actually put it on the patient's chest so I don't have to reach behind me or to the side or anything while I'm going. And then I'll get my finder needle, and we'll go ahead and do the triangle technique. So I have the vessel centered on my screen, and to the center of the vessel is approximately 2 centimeters in front of the vein, right in the center of my probe, at a 45-degree angle to the probe in this plane, and a 90-degree angle perpendicular in this plane. And I'm going to go straight in towards the probe and aspirate until I get in the vessel. And one can see that I did the triangle technique right on, because you can actually see my needle tip in the center of the vessel. Now we're going to step back and just really quickly show the other techniques. So as for the other techniques, I can take my needle and go right on top in the center of the probe when I'm centered on the vessel. I go straight in as I aspirate, and I'm in. And I can tilt back, still seeing that I'm aspirating, and then I can cannulate my guide wire. Another technique is to actually put the ultrasound device right on top of my needle. And I can actually see my needle tip at the top. And as I'm going in, you can see on the screen, I'm actually following my needle tip. Now it's right at the surface of the vessel, and now it's in. You can actually see it going all the way in. The fourth technique is doing the longitudinal view, where I have my vein lined up longitudinally, stick my needle in, and you can actually see my needle coming in and entering directly into the vein. So if I'm doing the catheter over the needle technique, I would do it just like a regular insertion. 1.5 centimeters back, I'm going in until I aspirate. Once I get flush, I'm actually going to keep my right hand steady and slide the catheter right in all the way to the hub in the vessel and cover the opening. And then I can actually take my guide wire and actually thread it right into the catheter directly. This may be more advantageous for patients that are extremely volume depleted, where you have concern that your needle is going to be going in and out of the vessel when you're holding it in place. The catheter is in the vessel for a few centimeters and will stay in place. One technique I can actually do here is I can actually confirm that I'm in the vein by transducing a pressure or doing manometry. So some kits actually come with tubing that I can just actually connect to the tip of my catheter or even my needle. I like to do it to the catheter just because it's a little more stable of a system. And I'd actually hold up as a manometer, and I can actually watch the column of blood coming up to ensure it doesn't go high and is not pulsatile to suggest that it's in the artery. So now we're going to actually go back and do the full triangle technique insertion. So I'm centered. I'm 2 centimeters back, going forward until I get in the vessel. I can put my ultrasound down. I need to take care to keep my right hand very steady so that the needle does not migrate forward or pull out, because then I can either go right into an artery if it's below the vein, or I can actually come out of the vessel. So what I do is I grab the needle in a C-clamp, holding my index finger and my thumb on the tip and gripping it very tight so that if the patient moves or anything moves, that the needle moves with the patient. And one can see I can still aspirate and draw back. I come off, the blood is dripping. If you so desire, you can cover the hole. But as long as the blood's dripping out, you're not at significant risk of air embolism. It's more if the blood is sucking back in. And I will put my guide wire in. And what you notice on the guide wire is a one mark, one black dot. That indicates the 10 centimeter mark on the guide wire. So I will go in, and then one sees the next mark, which is 2, which indicates the 20 centimeter mark. There's no reason to ever really put more than 15 centimeters in the patient, so that if I advance my guide wire so that the 20 centimeter mark is in the glass window of the syringe, there's about 5 centimeters to the patient. This is about 15 centimeters total in the body. Now that the 20 mark is in the glass window, that's about 15 centimeters in the patient. I can take off my guide wire holder, gripping the guide wire up here. I'm going to come off. Now please note that some guide wires in older kits don't have these marks. So what I recommend is actually knowing some centimeter marks of standard configuration of your hand or of your finger so that you really can measure directly how far you're sticking the guide wire in. Next step is to come out with the actual finder needle. So one technique that I find particularly useful to ensure that the guide wire is actually in the vein as opposed to the artery is to actually ultrasound the guide wire. I believe this is important because we want to make sure before we dilate that we're actually in the vein and not in the artery, because dilating the artery can be devastating for the patient. So what I'll do is I'll take my ultrasound probe and first do a cross-sectional view through my vessel. And as can be seen, we see the actual guide wire going in the vessel, and it's clearly in the vein. But often, because of shadowing that's under the guide wire, we can't tell if the guide wire is going right through the bottom of the vein. So what I recommend in that scenario is to actually turn on the guide wire and actually do a longitudinal view. And there on the longitudinal view, you can clearly see the guide wire coursing through the vein and not going through the bottom. Then I will dilate and I will cut the skin. So I have my scalpel and my dilator. I'll make a nick in the skin away from the guide wire to make sure that the dilator goes in. There may be some bleeding here, so you can take some gauze and stop. And then the next step, again, never letting go of the guide wire, is to take my dilator and thread it. And with a twisting motion, more closer to the skin entry, I'm going to enter with my dilator. You do not need to hub your dilator all the way. Just put your dilator in on a real patient until you feel a given resistance suggesting that you're in the vessel. Aggressiveness with the dilator may bend your guide wire and is not recommended. Now we're ready to actually thread the catheter on the guide wire. So as we discussed before, I'll thread it through the distal port and it should come out the brown port. And again, that would be red on a Cook catheter. So I just advance it until I see it coming out. I grab the guide wire on the other end, and then I'll hold the guide wire in place without advancing the guide wire at all, so locking it in place, and I'm just sliding my catheter over the guide wire into the internal jugular vein. Now, assuming our patient is an average size, this is a 20 centimeter catheter, I'm actually going to insert my catheter into about the 15 centimeter mark. So now that I'm at the 15 centimeter mark, I'll hold my line in place and I'm going to start coming out with my guide wire. Now note that blood is going to return through this distal port, so I like to clamp it as soon as the guide wire comes out so it doesn't have a chance to clot. There's actually a little clamping mechanism that I can just slide across when the guide wire comes out. Guide wire is coming out and we're clamped. So the next step is to make sure all my ports are working, and I'm going to flush the brown or red port first just because it may have a little bit of blood on it. Now remember, I'll take my other cap that I had already pre-flushed, I'll put it on, I'll unclamp the line, and then I can aspirate and flush. Now I like to actually aspirate only a little bit just to see a little bit of blood getting into the lumen of the vessel. I don't like the actual blood getting into my cap just because it's harder to flush it out. So I'm going to aspirate the blood back. It's coming. I'm going to inject. Okay, so brown is done. The next one will be white. I'll aspirate and inject. And then finally blue. I'll aspirate and inject. Now that all my line is actually flushed, I'm ready to secure it in because we know it's working. So I will take my white and my blue connectors, the blue part, and put it right on top. And I actually have to pinch it on top with one finger under the line and one thumb on top of it and just squeeze it together. And once that is set, it's on. And I can start to get ready to suture my line. And I like to fold my line into more of a user-friendly position. So I will actually tend to fold it back on itself so that the actual ports are not by the patient's airway so that they can get contaminated. So what I'll do is I'll take a bite through the skin. And then I'll back through my needle so that I don't poke myself. And I'll come through. And I want to make sure I pull the thread through enough so that I can continue to use my needle to suture the others. And I'll actually tie it down. Not too tight so that someone can easily get it when they're done. And tie it through. Okay. Once it's tied in, I would cut the wick off that's left over with a cutting needle, and I would suture it here as well, and then at least one of the other sites. So I could do here, and in some ICUs they actually like both of these done so that it's secured. Next, I'm ready to put my dressing on. I'll put on my gauze, and if needed, I'll clean off any excess blood with a chlorhexidine wand. Because my Tegaderm chlorhexidine dressing is too big to fit through this opening, I'll kind of lift up here, take my drape off, continuing to cover with gauze. I'll get ready with my chlorhexidine sponge, and I want the sponge actually to be right over the opening of where the catheter enters into the skin. So we'll put this down, and then we'll pull off the wings like so. So now that my dressing is on, we're going to order a chest x-ray. If the chest x-ray confirms that the line is in the proper spot, we will confirm that in our computer system or notify the nurse that the line may be used. In the next module, I will be demonstrating how to insert a catheter into the subclavian vein.